Cool.
Thank you for joining us. Like everything in the world, the pandemic has completely disrupted the way emergency medicine operates. I have some questions about that. I'm sure you do too. So later this evening, we are going to have an excellent panel discussion where we dive deep into some of those questions. But before we get there, I have the great pleasure of introducing Adair Roberts, who has combined her passion for frontline workers with her passion for local restaurants. And both have needed a lot of support and love over the past year, and she has stepped up to provide that for both communities. So Adair, over to you. Please go ahead and introduce our dinner for the evening.
Thanks so much, Sarah. Hello, everybody. As Sarah said, my name is Adair Roberts. Just to give you a sense of who I am, I'm an independent consultant who's worked in mental health and addictions for the last 20 years now in the sector, working with organizations to help deliver services better. That's where my understanding and awareness of what the pandemic must have meant for frontline workers in the very earliest days back in March 2020 and before that. And what happened really was that I was sitting at this very desk and heard that the restaurants were closing down. And I actually have some friends in New York who run restaurants, and I wanted to help them. And this idea came into my mind of raising funds to be able to purchase meals from local restaurants, individual owned and operated, and deliver them to frontline workers. That's what I did for them. I made a donation to them. They delivered it to a hospital I found in New York City, and it was an amazing experience, just very random happening. And I got happy pictures the next day and realized we were onto something. So we started what's called Feed the Frontlines TO in Toronto. Fast forward, we ended up delivering about 25,000 meals, I think, to frontline workers across the city. I think we delivered about 3,000 to UHN over the period. So I was happy that we were able to do that. And in about the summer, when frontline and social service agencies, hospitals got it all under control, and I think things were settling a bit, we actually shifted and started delivering meals to people who are facing food insecurity, another key issue in our city. And we've delivered another 25,000 to them. So that's our little organization. We're very grassroots. We had a big team. Now it's just me. And we're continuing on. So I just am thrilled to be able to introduce one of our restaurants that supplied the meal for tonight, Pukka. Pukka actually has two restaurants, one that opened right at the beginning of the pandemic or shortly thereafter. And who we have with us here today is Derek Vello. Derek has been on the restaurant scene in many different capacities over many, many years. He's co-owner with Harsh Chawla, Pukka. And Derek, maybe I could pass it over to you and you can tell a little bit about the food everybody's having tonight.
Thanks, Adair, and good evening, everyone. I had the pleasure of driving around Toronto today and dropping off meals. A lot of people I saw face to face, which was great. So I'm very honored to be part of this tonight. We came on shortly after Adair kicked off last year in April. She started in March. We came on board in April. And for the restaurant Pukka, we have managed to keep probably 97% of our staff, partly through Adair's efforts in Feed the Frontline. So it's been a great addition to our cash flow through the past year. Hopefully that is coming to an end, as we keep saying that we hope this comes to a happy ending soon. Anyway, for tonight's dinner, everyone has received one of our signature dishes, the Pukka Chat, and I've always described this as the closest thing to a healthy salad in Indian food. I hope the directions helped everyone put that together tonight that were in the bag. And then two dishes, the butter chicken, which is probably the most popular dish of Indian food, especially here in North America. Fairly self-explanatory. And then a fun little dish called vegan tikka masala, which is a riff on the UK traditional dish of chicken tikka masala. Basically peppers, tomato, sorry, I'm getting zoomed here. tofu, peppers, onion, tomato, and it's completely vegan, and inspired my daughter, who is a vegan. So hopefully you enjoy those things tonight. The chocolate torte has a little bit of chili in there, so there's a little bit of a kick. But we're known here for being a little more on the tamer side of the spice level. So I think everyone should be just fine with their meal this evening.
Wonderful. Thanks so
bit.
much, Derek. I live not too far from your restaurant on St. Clair, and I'm a big fan. So thanks so much for participating this evening.
Oh, thank you. It's really it's an honor to be on here in our little capacity. Thank you.
Excellent. So now let's dive into our panel. We have 3 panelists with us tonight. Dr. Sam Sabbah is the Medical Director of Emergency Medicine for UHN. Councillor Joe Cressy, Chair of the Toronto Board of Health and City Councillor for Spadina-Fort York. Thank you for joining us. And Deb Matthews, hello, your screen is working. Good to have you with us. Former Deputy Premier and Minister of Long-Term Health and Long-Term Care, and now a board member at Western and Toronto General. So thank you so much for joining us. I have this amazing Western facing light coming at me, and I'm now just going to pull my blind down so I'm not completely blinded. Oh, that is so much better. Thank you for your patience. So emergency medicine. Let's have a conversation about what's happened over the past year. People say, and this I'll go right to Dr. Sabbah, people say that the pandemic is a kind of accelerant for many trends that were sort of embryonic pre-pandemic and are now in full bloom. So one of the most interesting things going on in your emergency rooms is the introduction of virtual care, which is a fascinating new tool in your toolkit. Can you tell us a little bit about how virtual care works, what its strengths and even what its weaknesses are?
Thank you, Sarah. That's a great question. And it's interesting that we first started working on virtual care in November of 2019. And at the time when we started, many people told us that, you know, it's going to be impossible to do emergency care through a virtual platform. It just, there's no replacement for a physical assessment and being there with the patient in person. And we faced a lot of, you know, resistance and skepticism when we started talking about it at UHN. And, you know, fast forward a few months and we were right in the thick of the pandemic, and people were scared to come to the ED. We had providers who were also had their own medical problems. Some were advanced age and were really worried about what it meant for them to be exposed. And then people were very interested suddenly to look at virtual care. So the way we have done it at UHN is we wanted to get things off the ground as soon as we could. And then we are aiming to continue to expand the scope of what we're doing and the complexity of what we're doing. So we started very, very simple, basic scheduling software. You go in, you request an appointment, someone calls you at that specific time, and you have a conversation. And we rapidly iterated on that. So where we are today is we have a triage system that's facilitated by a nurse practitioner who does some screening questions to make sure that the call is appropriate for virtual care, or whether it should be redirected to perhaps an outpatient appointment or an assessment by a family physician. Or it's actually quite concerning and it sounds like the person needs to come into the ED right away. So the nurse practitioner screens the call and then sets the person up with a provider who will use Microsoft Teams video conferencing software to have a conversation with the patient and do the assessment. And this has worked really, really well. The feedback has been exceptionally positive from patients. It's very convenient, it's accessible, they feel safer, they don't need to come into the emergency department unnecessarily, they don't need to get exposed potentially to infectious agents if they don't have to. And we found that 85% of patients who access our virtual ED don't actually have to come in. We're able to do the complete assessment virtually and set them up with appropriate service. And where we're hoping to go with this is that soon in the next couple of months, we're going to take it one step further and actually integrate an artificial intelligence engine in it to help facilitate that appropriate triaging and also help coordinate tests and radiology and follow-up. So it's really, really exciting. And I think that it's clearly the way of the future. It won't replace every visit, but it has the potential to replace a significant proportion of ED visits.
That's really fascinating. Am I correct in understanding that the pilot project was partially funded by donors and your philanthropic supporters? That's wonderful. Can you, or maybe Deb, since you sit on the board, talk a little bit about the role of philanthropy in piloting projects that are not automatically already part of the provincial budget?
Yeah, this is a perfect example of an innovative project that wouldn't be funded. There's no pigeonhole for it in the ministry formulas. So this is a perfect example of where you can get money, not from the ministry, from philanthropists, to really transform healthcare. It's so this kind of innovation is possible only if donors make it possible. But if I can,
go ahead.
I have to say, but I think I heard Dr. Sabbah say that 85% of the people did not need to come in. So that will generate cost savings for sure down the road, but the money isn't always, as they say, fungible. You can't always move it around. Like you can have cost savings. That doesn't necessarily mean the initiative that generated the cost savings will be funded.
There was a time in very recent memory when our biggest concern with emergency rooms was hallway healthcare.
Yeah.
I don't know, maybe Dr. Sabbah, if you could comment a little bit about whether that is still a concern, how that concern, how the pandemic affected that. I mean, did we go from overcrowded emergency rooms to underused emergency rooms?
It's an excellent question. So hallway medicine is a bitter reality, I think, of many, many EDs throughout the developed world. And there's no doubt that it's associated with poor patient outcomes. This has been demonstrated time and time again in multiple settings. And it, unfortunately, UHN was not spared. You know, we are very much living hallway medicine even today. It's terrible for patients, and it's actually one of the major causes of moral distress and burnout among providers, because we all aspire to provide a better standard of care to our patients. So what happened just pre-pandemic, I think we were at our peak in terms of overcrowding. For example, at the Toronto General site, we're seeing close to 60,000 visits a year. Our ED was designed to see 20,000. So we're seeing triple the volume of patients the ED was actually designed to accommodate. And what meant was that people were put in unconventional spaces. We had people in the hallways, we had people in areas that were not intended to be patient care areas. And anywhere where we could fit a person or a chair, we would put someone. In the early days of the pandemic, what happened was, as people were worried about coming into the emergency department because of COVID, we did a reduction in our volumes, and that helped a little bit with the overcrowding situation. But unfortunately, COVID challenged us in a different way, which is that every patient who screens positive for any symptoms of COVID actually needs a unique, like an isolation space. So we went from being able to put 4 people in a room to now being only able to put 1 patient in a room at a time. So even though the volume had gone down, our functional capacity had decreased. And we estimated about a loss of 40% of capacity. So we still had challenges, and now our volumes are back up and things are picking up as people have waited really long in the community to seek care, and they've deteriorated, unfortunately. So they're coming to see us quite sick, and we don't have the space. And so we're doing things now that, you know, I think a year ago we would have said there's no way we would put patients who are rule out COVID in a hallway. Unfortunately, we're doing it now.
That is a upsetting portrait for sure. I have a question for you, Joe. One of the things that's so exciting about Toronto is the number of condo towers going up downtown. It's a incredibly desirable place to be. And there will be is an ongoing densification in the city. And I'm wondering if these ERs will have capacity to cope with the population that we are so happy to see living in the core.
Well, I guess there's 2 things. I mean, the first is, you're right, Toronto is growing in downtown in particular. Just to put it in context for folks, we're anticipating the city of Toronto, we're going to add about 1 million people to the city over the next 20 years. Downtown Toronto, this little tiny core from Bathurst in the west, over to the Don Valley, from DuPont in the rail corridor, up by where you live, Sarah, right down the waterfront. That little corridor, it's 17 square kilometers. About 250,000 people live there today. I'm one of them. We anticipate that number will be 500,000 within the next 15 years. So doubling of the population over 15 years in downtown. If you're going to double the population, you need to increase the services to serve that growing population. And that's health services and it's emergency room services, just as it's also schools. A livable city is one where you can access healthcare, just as it's one where you can send your kids to school when you need it. So the simple answer is yes. As with growth coming in our city, we will need to continue to expand the health services on offer, including the ER rooms. But one thing I would just flag is something that COVID has really pointed to, is that the emergency room, it's often been seen as a point of last resort. How you make it more accessible, how you make it easier to access, how you deal with issues like hesitancy, whether it's due to a COVID pandemic or other issues, that's a really critical leading point that I think part of what Sam was just talking about. There's how do you turn the ER model on its head to serve everybody, no matter where they're coming from, and no matter what barriers they may have. And I think that's part of the innovation we're hearing here tonight that is so critical going forward.
Can you name some of the ways, Joe, that you've seen ERs become more accessible and open to diverse community members?
Yeah, I mean, one of the ways that I would really point to, and this is something, here where UHN is part of the discussion tonight. And one example I'd point to is, there's a social medicine division within the University Health Network. And they've started piloting putting social workers in the ER section, because you have a lot of people coming in crisis and they have acute health issues that they need addressed. But these are also people often who are homeless, people who are dealing with substance use issues, and they need support within the ER system to deal with whatever the acute health issue is there. But then you need also somebody to help provide access and referrals and services to other issues that may underpin that arrival at the ER, whether that's referrals for housing and substance use support. And so that's an innovation that I know didn't come about because of COVID, but in a time of COVID where so many are struggling on our streets, it's become more important than ever.
Sam, can you comment a little bit about what that looks like from where what's working in that model and what it feels like on the ground?
Yes, for sure. So Thankfully, we've actually had social workers in our EDs for some years now, and they're critical components of the multidisciplinary team. But I think, Joe, what you were referring to is we actually recently introduced peer support workers. So these are people who have lived experience as struggling with mental health and addictions problems and domestic violence and all the challenging psychosocial determinants of health. And they're in the ED as a bridge between the patients and the providers. They're not there to give medical advice. They're not there to do medical assessments. They're there for the patients. And what we've found is that it's really changed the dynamic. Patients who are in crisis have often, unfortunately, had negative experiences in hospitals in the past. The system has let them down so many times in so many different ways, and they just don't trust the system or the providers. And having a peer support worker who they can relate to, who can translate their concerns, who can their advocate in the emergency department has been incredibly helpful. And if you go back, let's say 2 years, that same patient would have probably been what we would have labeled as a challenging patient, difficult patient to encounter. Many would end up escalating in the ED, would lead to needing to restrain by force and provide chemical sedation and all of that. And instead now they come in feeling vulnerable, threatened, and scared, but then they see someone that looks like them, that has their life experience, and they can immediately make a connection and everything de-escalates. It's really been a wonderful experience.
That's really fascinating. Over the course of the pandemic, there's certainly been the pandemic has exposed all manner of cracks in our society. And this is a question for you, Deb Matthews, having studied the way provincial healthcare is funded for many years. Where do you see sort of the greatest deficiencies in our system? Where if you could wave a magic wand and pour buckets of money into one particular area, where do you think that money should go?
Will you let me give it to 2 areas?
100%, yeah. That's the great thing about magic wands.
So the first one, I would absolutely address the social determinants of health. There are so many people, Sam would have the statistics on this, who go to the ER. I mean, there are people who go 300 times a year. Am I right, Sam?
Yes, and
more than that. So that means almost every day the same person goes to the emergency department. Clearly, they have a need, and clearly the ER isn't meeting that need. So, so people with big challenges, if we would take care of them outside the healthcare system, that would be way better care for them. It would be way more cost effective for the healthcare system. So addressing the social determinants of health with the basic income, with a housing strategy. I mean, how can someone who is homeless take care of themselves? How can they self-isolate? So addressing homelessness, the social determinants of health for sure would be a big bucket. The second big bucket would be in elder care. We have over the years built up a system where there aren't a lot of options for older people. They can stay in their own home with some supports for a while. They can supplement the supports if they can afford it, or they're in long-term care or even worse, hospital. So we need to build the continuum of care for our elders so that they get all the care that they need, but not more care than they need, because if you're not a wealthier person, you probably can't afford that extra home care. You can afford the long-term care because of the way that pay structure is works. So you certainly couldn't afford a retirement home. So I think we really need to look hard at what is that continuum support for our elders, which might not actually cost money in the long run, because they get better care and it's probably less expensive care.
Joe, I can't resist asking you this week what everyone is wondering about, which is vaccines. So how has the community vaccine mobilization campaign been going? Where are we at? What's working? What's not working? I feel like I have a direct pipeline to the guy at the center of it all, and it's what's on everyone's mind.
Well, I mean, let's start with vaccines in terms of, the first step. You need a safe and effective vaccine or vaccines. We have that. That's step one. The second step is you need accessible vaccine clinics located in a manner that are available throughout the city. Ultimately, there is a plan in this city for more than 350 clinics between our hospital, community health, and city partners and pharmacies. In the meantime, just today, we had 30 clinics up and running in the city of Toronto between hospitals, the city's mass immunization clinics, and around 200 pharmacies. So you need a clear vaccine and you need clinics. I would say we are on the road to having the accessible clinics. But ultimately, you need people who can access these clinics, are able to register, and are able to get there. And I think this is going to be, to be honest, I think the issue as we go forward in the city, so much of the discourse to date has been, why aren't the vaccines rolling out quickly enough? And that's a critical issue, because the faster we get them out, the more lives we can save. But ultimately, this conversation is going to be about, are we reaching mass uptake of vaccines? Are we actually getting to herd immunity, where you have more than 70% of the population or more taking it? And that's the challenge, is in a city as diverse and broad as ours, you need a vaccine campaign that engages and reaches every resident in every corner of the city in the language they choose and addresses their barriers that they may have to accessing it. And so that's where the rubber is going to hit the road over the next couple months. I mean, I could go on at length. We've built a model at the city to 280 neighborhood vaccine ambassadors, trusted local leaders in your community making the case for vaccines. We've invested $10 million into 140 community agencies, multilingual, trusted local agencies on the ground, going door to door to help people register for vaccines, to help get them to the clinics, and to address any barriers. But that's the type of ground mobilization this is going to take. There was this hope we'd open the clinics and everybody would show up and we'd be done. But that's not what's going to happen here. This is going to be a long campaign that's going to have to build trust and break down barriers, and that's how we're going to beat it.
So essentially, we're going to go from a supply problem to a demand problem. Dr. Sabbah, I know this is not your field exactly, but I imagine you have vaccines on the mind as much as everyone. What do you identify in your travels and what you're hearing and reading and the patients you deal with as their barriers? What is that at the root of the hesitancy that Joe was identifying?
Yeah, that's a really great question. And I think it's multifactorial. Part of it is, I think, as a non-expert in vaccine rollout, as an emergency physician, from the outside looking in, to me, it looks like we really tried to aim for perfection in our model initially, so that we wanted to distribute vaccines perfectly equitably, and we wanted all the right criteria to stratify people. And what ended up happening is we ended up with a very complicated system that is difficult to navigate. And hindsight is 2020. But as an emergency physician who sees people who are sick with COVID every day, I really wish we would have aimed for speed over precision, and accepted good enough as a strategy and just rolled it out and did it. So I think a big part of it is the complexity. I have family members who have struggled to register, have had a hard time navigating Different hospitals had initially set up their vaccine registries before the ministry came on. It wasn't clear how they all interacted, and if they were registered before, do they need to do it again? So I think a big part of it is the process was very, very complicated. Another factor here is, I think, the fear of the unknown. We have a history of longstanding vaccines that we've had for decades, and everyone knows what to expect in terms of long-term complications. Most of these vaccines are brand new. Some of the vaccines are brand new technology, like people hear about messenger RNA, and what does that even mean? And it's quite confusing and frightening. And I think, as the science has evolved and our recommendations have changed over time, that's also perhaps contributing to some lack of confidence among people. So one thing that we've started doing in our emergency department is we actually have little pens that say, "I've been vaccinated, ask me questions." And you'd be surprised at how many people have really, really good questions about, how did we authorize this? What does emergency use mean? Does it mean that we skipped steps in our authorization process? How did we come up with a vaccine so quickly? All these very relevant questions. And I think the key moving forward is going to be consistent, clear messaging around what we know and honesty about what we don't know. And I think that's how we'll win the trust of the people and build confidence in the vaccine.
Joe, do you have anything to add to that? I know you've probably spent countless hours thinking about these questions over the last few months.
I think there's a couple things. I think the first is you want to make accessing the vaccine as simple, clear, and easy as possible. And the harder it is, the more challenges it creates. And I think what Sam was speaking about there is accurate, that in a strive to create an ethical framework that tiered every vulnerable group, it created a model inadvertently that was hard to understand. When's it my turn and where do I go to register? That's all people want to know. And so I think in an attempt to create an ethical framework based on risk, it created a lack of clarity and confusion that leads to barriers to access. The issue of hesitancy is a really important one, because even before COVID, we estimate that about 20% of Canadians identify as vaccine hesitant. That doesn't mean they're opposed to vaccines. It means they have questions, they have concerns, and they want answers. And what the research has said is the biggest driver in shifting somebody from being vaccine hesitant to taking a vaccine is when somebody they trust talks to them about it. Their family doctor, a member of their extended family, close friends. And so when I think about this next phase of the vaccine campaign, as we seek to encourage mass uptake, all those people who have taken vaccines, they become the biggest validators for us out there. It's not me, it's not a government official or the chief or the medical officer of health. It's going to be your family physician or your grandma, and I think we have to build a campaign that builds trust just as it builds access.
Deb, do you have anything to add to that? Because it does seem to be like the big challenge of our time, and I'm curious to know if you have any observations or ideas to add.
Well, I'm happy to see the number of people who are vaccine hesitant is really declining, so that's good news. But I'm very concerned about the people who work in healthcare and long-term care homes and in our hospitals who are not getting vaccinated. And that's a tricky issue. I know I had to deal with it when I was Minister of Health, but I think we have to really invest the time with the people who have not yet been vaccinated, who are patient-facing, and make sure that everybody has the opportunity. And if they need paid time to go get it, or if we need to, we have to figure out a way to get everybody vaccinated, as many as possible.
Joe, I remember when you first took over the public health file with the city, you had already a crisis on your hands, which was the opioid crisis. And then we were hit with another crisis. So we sort of had two, one on top of the other. Can you talk a little bit about where you are and the city is in terms of fighting the opioid crisis now, this far into the pandemic? And I'd like to hear Dr. Sabbah after that, because I'm sure you're on the front lines and you see what that looks like.
Sure. And, I think the sad reality is that even before COVID began, we had an overdose epidemic facing our province and our city and our country. I mean, to put it in context, we've had more than 17,000 Canadians die over the last year due to overdoses. In Toronto in 2019, the year before the pandemic, we had more than 300 Torontonians lose their lives due to overdoses. And these are preventable deaths. I mean, this is the one critical thing to recognize. Overdoses, when you tackle the overdose crisis from a public health perspective, treatment, prevention, and harm reduction, we can save these lives. Now, during COVID, the issue of overdoses it's accelerated dramatically. We have seen in Toronto that in 2020, we had 450 overdose deaths. That's up from 300 the year before. Every month, we've seen a rise in overdose deaths month over month, attributed to the increased trauma associated from the pandemic, border closures disrupting illicit supply of substances, creating a more tainted drug market than we had before, and also a reduction in services that are available to people. People, to be honest, we opened more than 20 hotels for people who are homeless as a way to enable physical distancing. But then we saw an increase in overdoses because people were using drugs alone in their rooms in the hotels. And so, all of this compounded on top of each other. And, I guess I look at this crisis around overdoses, and I look at it from the perspective of how we've approached COVID. Governments have come together to follow public health advice some of the time, hopefully a lot of the time, but to treat it with the urgency it required. And I can tell you that if we did the same approach on the overdose issue, that we would save lives. These are preventable deaths, and Sam will see it on the front lines, but it has been a very difficult year in our city on that front.
Sam, what have you seen from where you stand?
It's a really sad story, and I can say that it's grown exponentially over the last several years. When I started at UHN back in 2009, especially at our site, I think we would see one opioid overdose every maybe 5 or 6 shifts that I worked. I would see one person. And my record now has been 9 overdoses in one shift. And it's really quite like a real health crisis. And it's a lethal health crisis. Like, people die, young people die who otherwise, their whole lives to live out and could be very significant contributors to society. And the challenge with this is that it crosses all psychosocial demographics. So we have people who go from being professionals to becoming addicted to these substances to ending up on the street. I've seen people gradually deteriorate. The first time they come in with an overdose, they're wearing, they're very well dressed in an expensive suit, and as time goes by, you're seeing them getting progressively more disheveled and unfortunately unkept, and they look like they've lived on the streets for a long time. I think everything that Joe mentioned in terms of how to address this is critical. The harm reduction models are critical. I think COVID has challenged people who are suffering with mental health and addiction has really compounded their isolation and has contributed to a lot of these lethal overdoses. So, it started pre-pandemic, as you identified, Sarah, and I think the pandemic has accelerated it.
Sarah, if I could just add something to this. I think we need to get serious about safe prescribing of opioids. I think if we, on one hand, say addiction is an illness, but we treat it like a criminal act, then we're not going to be able to solve this problem. I think if people have an addiction, safe prescribing could save a lot of lives and help people get to where they want to be. So that's not maybe a popular opinion with the general public, but I think we need to tackle that.
In a few minutes, we're going to open this up to questions from our audience. So audience members, if you have questions, please put them in the Q&A box. I have a slightly lighter question for you, Sam. You have described a fast-paced, ever-changing, very heavy-duty universe. And I'm curious to know why you chose to go into emergency medicine. What attracted you to that field? And is it what you thought it would be?
That's a really great question. I think if you asked me when I applied for a residency in emergency medicine, my answer would have been, that I find it very challenging, and I like the idea of never knowing what's coming next. And I feel like I have the skill set to be able to think on my toes and to really very quickly make decisions with little information. And that was the initial appeal. About a couple years into residency, I realized that it's actually so much more than that. And what attracted me to it initially was important, but it actually fades after some time. But what kept me in the specialty and what keeps me going now is this sense of purpose. We're here for patients when they need us the most. And that's an incredible privilege. And it's a source of such gratification that I think, it's a tough job. The shift work is brutal. The environments are loud, they're harsh, but it's incredibly rewarding. And, knowing that people who come to see us are probably having the worst day of their lives. And if we can make it somehow better, we might not be able to change the outcome, but if we can change the experience, then there's something really special and privileged about that. And it's something that keeps me going.
That was so heartfelt. That was, I don't know if everybody, Sarah, how you felt. I just heard that. I'm like, I want to be a doctor now.
Joe, we need you on council.
I have an interesting question from the audience about this. I even hate to say these two words together, future pandemics. But of course, there are some very serious scientists who think that this is a preview of some other worse pandemic that might come at us down the road. I shudder to think. But I imagine if you're working for the province or the city or at a major hospital, you actually are obliged to think about it. And I'm curious to know, Dr. Sabbah, what UHN and what you've seen the province and maybe even the country do to prepare for the possibility of another pandemic.
Thank you. It's a really important question. I think in many ways we got off easy with COVID, which is hard to imagine given the amount of suffering that we've all experienced. But you could change one of the variables, with this virus, and it could have been several-fold worse. So if you took it from its current mortality rate to like a mortality rate of 3 or 4%, then the amount of pain and suffering and death it would have caused would be magnitudes higher. If it were airborne instead of droplet transmission, which means if it could travel long distances, then it would have infected millions of more people than it currently does. And we know viruses do this. So in many ways, this is a dress rehearsal for something that is potentially much worse. So what I think we must do, and what I've seen, we have been doing it throughout the pandemic, but people tend to have a short-term memory with regards to things like this. And you know, we've had opportunities to learn from SARS and from H1N1, but then somehow we move on and it becomes less of a priority. But I think we must continue to invest in emergency preparedness and pandemic preparedness. You know, there's no glory in prevention, as they say, but it's absolutely necessary. We have to build infrastructure so that we're not dependent on the supply chain for PPE. We have to invest in our own vaccine capacity. Basic science research is critical, and hospital acute care is critical. And I know over decades, we've said that, you know, hospitals are expensive and inefficient, and we've tried to push care outside of hospitals into the community. And I think that is absolutely important. But when you're faced with an emergency, there is really no replacement for those ICUs and those critical care beds. So I think we need to continue to look at our acute care capacity and our critical capacity and anticipate that the next time around, we might not get off as easy. And it's hard to even say those words given how tragic COVID has been, but it could be much worse.
Deb, I believe you were in government during H1N1, correct me if I'm wrong, but I'm wondering if there's some lessons from that experience about pandemic preparedness that you have, you want to offer this group.
Yeah, I'd been health minister for about 2 weeks, I think, when H1N1 hit. So it was truly trial by fire. I guess, you know, many lessons learned from that, and even more from SARS, I would say. But I still find it incomprehensible that we haven't figured out how to have a vaccination database where we know who's been vaccinated for what. It kind of blows my mind. So for starters, I think I would focus on getting that vaccination database. Maybe Dr. Sabbah could tell me I'm wrong, that it does exist, but I don't think I'm wrong.
Go ahead.
It exists in various formats. I think, you know, I don't think we have a unified vaccine database. You know, that is, I think it's a critical piece of the infrastructure, but there isn't an easy way for us now to see who's vaccinated, how many people are still waiting for their vaccine, and what type of vaccine. There is a provincial database, but there are also parallel databases. We have our own registry, for example, for our staff at UHN, and some people will have received the vaccine elsewhere and we don't know about it internally at UHN. So it is, I think there's lots of room for improvement there.
Earlier in the, go ahead. Earlier in the evening, Joe, we were talking about video conferencing for emergency visits. And we were also talking about access and inclusion. And of course, the city, there's a large digital divide in the city between people who are comfortable with technology, have access to technology, good Wi-Fi, working devices, can figure out how to navigate the system. Sam, I also was trying to sign my parents up for the vaccine. I found it confusing and maddening, and I had many resources at my disposal. But Joe, I'm wondering if you know, one of the audience members was asking about the technology aspect of access. So how does the city, if we're moving to a more digital universe where many services, including emergency medicine, are transmitted digitally, how do we make sure our citizens have what they need?
Yeah, and I think, you know, in so many ways, I've described the COVID experiences, you know, COVID is a mirror, you know, it lifted up a mirror and everybody got to see what our city actually looked like and where the cracks were. And you the truth was kind of hard to see. I mean, just paint a picture and dive into the digital divide. Of all cases in our city of COVID since the pandemic began, 79% of cases are racialized Torontonians, 79%, whereas only about 50% of our population identifies with a racial group. About 55% of all our cases in Toronto are people on lower incomes, whereas about 30% of our city as a population lives on lower income. So the people who got hit hardest by this pandemic are low income and racialized Torontonians. And these are the same people who were struggling before the pandemic. And that was, the digital divide comes into play there. So the very people who need fastest and easy access to services, who may be struggling to isolate, don't have the access to many of the resources that are necessary. So some of the things that the city started to do and what we should do more of coming out of this, making Wi-Fi available in Toronto community housing buildings. Make Wi-Fi available for free. It's not currently available for free in all public housing buildings in our city. We started during the pandemic to make it available in some areas, in some buildings, but not enough. Addressing the digital divide means providing those digital devices to people who need them. That's a critical component. Again, we started through the city and Toronto Public Library as a partner to provide, a couple thousand digital devices, more to go. But addressing the digital divide means access to Wi-Fi and devices for connectivity, and it requires both. And it should be considered as a piece of infrastructure on a go-forward basis, given the connected world we live in. I mean, that's just the bottom line to me.
This will probably be our last question, and then we'll turn the mic over to some of our friends from the Impact Collective. Quite a few people on our call are asking questions about vaccines, not surprisingly. And one of them strikes right at the heart of my world in the media, which is the disinformation that is spreading like crazy. We've had a disinformation problem before the pandemic. We certainly saw that in the American election. All kinds of things are floating around social media, depending on what your echo chamber is. How does public health, and maybe Joe, I'll start with you, even begin to go up against convincing sounding lies? You mentioned arming community leaders with good information. What are some of the other ways that public health can fight the disinformation? Or maybe you don't see that as your job and that's more my job, but I'm curious to know where you land on that.
I think our work comes in a number of areas. I think one is a claim that's unanswered is a claim accepted. And thus, when misinformation is out there, it needs to be confronted and tackled and corrected. And so one of the big ways we're trying to do that is specific campaigns focused amongst targeted populations. So just today, for example, we just announced at the city a partnership with the Council of Agencies Serving South Asians. And so we've partnered with 10 South Asian agencies serving their communities to confront vaccine hesitancy and promote vaccines in their local communities, working specifically, in Bengali and Urdu and Punjabi in those local neighborhoods. We have a Black Scientist Task Force at the city, which has been hosting online webinars. We've had 9 webinars and more than 4,000 Black Torontonians have participated to confront vaccine hesitancy within the Black community. So one point here is you need to confront misinformation in every community by that community. And so that's resourcing the appropriate groups to do so. I think a second thing is clear, consistent public guidance and messaging. And I think this is where, it's got to be the doctor, not the politician, who's making the case. And so we look to our public health officials. And then the third piece here I would flag that may be seen as somewhat controversial, and this is something that we've raised, is with the social media providers, is to play a role in shutting down clear disinformation when it comes up. I remember a couple years ago, before the COVID pandemic, an anti-vax group tried to put up a billboard at Yonge and Dundas Square. Well, I called the owner of the billboard and they had it taken down. And because it was disinformation and it wasn't factual. And so I think we have a role to play in not only building trust on a community by community basis, and not only with clear public messaging, but also seeking to shut down outright lies when they are spread. And the social media companies, and that's a conversation we're having now, have a role to play in that.
For sure. That is a big challenge before us. This has been completely fascinating. I've learned a ton. I want to thank the three of you very much for participating. I'm going to hand the virtual mic over to our friends at the Impact Collective. And I know we have a few. There's Dan. Hello. Oh, look at you. The great reveal of turning your video on. And Raj, hello, hello. And Tiffany, over to you guys.
Thanks so much. And good evening, everyone. On behalf of the UHN and the Toronto General and Western Hospital Foundation, we just want to take a quick moment to say thank you for joining us tonight. My name is Dan Moulton, and my friend Tiffany Cress is here on the line, and we're founding members of the UHN Impact Collective. We joined this new volunteer group of emerging leaders because we were both inspired by the expanding list of research breakthroughs and new developments in community-driven healthcare at the UHN. And we're continue to be inspired after events like the one we're having here tonight. When we started planning this event, we reflected a lot on the importance of community building and community leadership in healthcare. We wanted to bring together a panel of experts that share our passion for equity and healthcare access. And so I want to thank all of our panelists and in particular Councillor Cressy and Deb Matthews for lending us their valuable time to this important discussion tonight. And we're also grateful to our partners at Feed the Frontlines TO and Puka, who who day in and day out are building a stronger community by feeding workers on the front lines and populations in our city that are experiencing food insecurity. Tiffany?
Yeah, that's right, Dan. The food was amazing, firstly, but also just want to say, like, it's events and discussions like this that really remind us how important collaboration is to building a vital city like Toronto. And thank you again so much to the panel for your very important work that you do for building a community and for our healthcare system, because it's this systematic change that really can lead to a more equitable society. You know, it's been a really challenging year for everybody, and it's conversations and it's action like this that really start to bring more positive hope. And so thank you all to the guests for joining today. Thanks for your support. We hope that you found this information informative and important, and that you'll continue to support UHN and all the amazing work that they're doing. You know, together we really can make an impact by learning and acquiring knowledge and supporting healthcare and really taking action. And that really is the next step. You know, and if you can spread the word, or if you want more information, you can go to the Toronto General Western Hospital Foundation website and learn more about the emergency room that's happening. Yeah, thank you again so much, and thanks for your support.
Well, I'll just be a quick word, Sarah, if I may. First and foremost, Sarah, thank you. I think Dan and Tiffany have said everything that needs to be said, but I want to thank you personally for hosting the panel. Hope you had a great Passover with your family and great Seder. I know it's been an important week. I also want to thank, and I tell you, Sam, you must be the best dressed or most person on this panel today.
I don't get many opportunities to dress up.
But anyway, it's again great to see Deb and Joe. But again, Toronto Life, I want to settle through you. I want to thank you for the ongoing support that we are, and we are very proud of our partnership and our association with you. Your support for the Serving Knowledge series has been tremendous in championing ongoing interactive conversations, dialogues about the game-changing initiatives that are taking place in the healthcare sector. Finally, to all the UIC members, thank you for being contributing to this, being part of this initiative, This is great. And Tiffany, to make it easy for you, from tomorrow, we are going to call ourselves the UHN Foundation. So you don't have to have the tongue twister of Toronto General Western Hospital Foundation. So I'm giving a secret away, but tomorrow we will be the UHN Foundation. Thank you.
That's lovely. Thank you so much. Thank you again to our panelists and to everyone for joining us. Have a great night.
Thank you so much for having us.